Cast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. This is Marilyn Francis from the Patient-Centered Primary Care Collaborative, and we welcome you to our presentation, Building Partnerships with Patients and Families to Improve Care. Next slide. And I just wanted to let people know that on the right of your screen, we do have 5 handouts that you're able to download, and we also have the chat box and a box for questions. You just need to press the arrow and the box will drop down, and we'll be monitoring that. So let's start. So our today's speaker is Mary Minetti, who's a Senior Policy and Program Specialist at the Institute for Patient and Family-Centered Care. She is an incredible expert on the issue of patient-family engagement and will be providing an excellent presentation to you on that issue of engaging families and patients. Next slide. So the objectives of today, as you can see, are to create a common understanding of patient-family-centered care and also to explore person and family engagement metrics and strategies to achieve them. We also want you to learn about ways to engage patient and families in improvement work, and then to discuss the Colorado Retina Associates opportunities to partner with patients and families. Next slide. Okay. So I know that most of you are probably familiar with the TCPI Transforming Clinical Practice Initiative, but I just wanted to show those the shared goals of meeting the aims for the TCPI, such as improving health outcomes, reducing unnecessary hospitalizations, reducing unnecessary testing and procedures, and reducing the overall unnecessary costs of care. And I know that through the work that you've done previously, you're very familiar with these aims and the interventions and the work that needs to be done in order to achieve them. Next slide. Okay, so I just wanted to give you an overall understanding of the PCPCC SAN, the Support and Alignment Network. So in general, in the TCPI community, we offer the virtual and in-person learning events, scholarships, especially to patients and faculty for conferences. We do virtual as well as some in-person coaching for patient advisors and practices. And we also provide resources on Choosing Wisely, which is the American Board of Internal Medicine Foundation program for informing patients on how to make collaborative decisions with their provider. We also provide expert faculty in this area of patient advocacy. And on our website, under patient engagement, we do have online tools and resources. And the other important resource that we have is the PFCC Connect, which is part of the IPFCC. And it's a virtual community for patient partners. And I encourage you to visit the PCPCC website. As you can see, the URL is on the slide, to look at our tools and resources that we have there. Next slide. And so our overall message is that patient and family engagement is critical. It's really an important element for effective and efficient clinical care. And the value of the SAN is that we support the PTNs and clinicians to help develop those collaborations and those that engagement between patient families and the communities and their clinical partners. And also there's an opportunity to accelerate these initiatives targeting cost and quality. And it's just, and we try to deliver the message or hope that people get the message that it's not just another thing to do. It's something that really, when integrated in your work and in your clinical practice, that it really does become just fully integrated and a part of what the services that you deliver. And also it really supports that patient and provider collaboration, which is so important for advancing quality. Next slide. So I will turn this over to Mary Minetti now, and she will be able to go through and give you some more of the details on how we approach the issue of patient-family engagement. So Mary? Is Mary, you may be on mute.
Sorry, I was talking to myself. I was on mute. Thank you, Marilyn, for the. Thank you, Colorado Retina Associates, for joining us today. I'm really excited to be working with you both in this webinar, but also as we move beyond just sharing basic information to action in your clinics. This is just for those of you that are interested. CMS has adopted person and family engagement as a strategic framework, and so they're aligning payment and expectations of clinics and hospitals and others related to that, and sometimes people are interested in that. So Tanya, I'm assuming I can move the slides. Have you given me control? Because nothing's happening. So what I want to do is I want to create a common language set and framework that you guys can share as you are doing this work together and advancing it. I know you're already started in this work, and so I'm going to talk a little bit about definitions and share a story with you that I think is a very powerful patient story about the experience of patient and family-centered care. So Tanya, the slides aren't moving. So what's important, so there are there's lots of terminology happening. So I want everybody to be really clear about what patient and family-centered care is, because people don't necessarily have the same definition, although we use the same language. So there are key principles related to patient and family-centered care, and I like to think of it as a lens through which we evaluate all of our work that we do in partnership with patients and families. One is that it's grounded in mutually beneficial partnerships that are built on dignity and respect. And dignity and respect really has to do with what are the values, preferences, beliefs of the patient and family, and do those drive how we organize care, how we work with individuals. Information sharing is the second key principle. So how do we as an organization, as a clinic system, share information with patients and families? Healthcare, as a rule, shares lots of information. In fact, sometimes we overwhelm patients with information, but how often is the information shared in ways that are useful and affirming so that the patient and family know what action they need to take in order to manage their care? Often we have, we aren't thinking about and building on the strengths of patients and families in the information sharing that we have. Participation is one of the key components of organization that's truly patient and family-centered. And it's not just that we invite participation, but that we also support participation. That patients and families are key members of their own care teams. Family is defined by the patient. So it may be somebody that has a blood relationship, or it may be that the elderly woman that you're serving in your practice doesn't have family close, but her neighbor checks in on her and drives her to doctor's appointments and those kinds of things. So medicine has been somewhat of a passive sport for many years, and so patients came into the clinic to receive care, and they were kind of passive recipients of that care. But when we start inviting patients and families to participate, they may not have the confidence to do that because we've kind of trained them to be passive. And so that encouragement, and how do we support that participation, and to the degree that a person wants to participate. And then collaboration, the fourth key tenet of any patient and family-centered care system, is all around how do we work with patients and families and collaborate with them in the programs and services that we provide. How do they help inform our improvement efforts and those kinds of things? So, and the other thing is that PFCC is all around building empathetic relationships with people and identifying what really matters to them. Can you move to the next slide? So patient and family-centered care, if you can only remember one thing about patient and family-centered care, and I apologize for this, that one picture, it doesn't look like it's working. Patient and family-centered care is working with patients and families rather than doing things to or for them. Tanya, would you move to the next slide? Let's just assume that the technology is not going to work because I'm in Oregon and you are not. And so I want to make sure that we emphasize the importance of family and patient and family-centered care. Often people drop the family out of patient-centered care. And what we know from the literature is that individuals who are most dependent on health care are most often dependent on their families. It's often the very young, the very old, and those with chronic conditions. And that families can be real allies for safety and quality because they're often the person that follows and partners with the patient across the different continuums of care. And so it really is important to be working with patients and finding out who they define as family, who they want to have involved in their care. Next slide, Tanya. We don't have a lot of time we're just laying the foundation. We have a lot to cover in this 1-hour webinar, but I want you to know in one of the downloadable handouts is a practical resource around continuing the conversation with your staff around creating a culture of person and family engagement, patient and family-centered care. And what I would say is that if you think about, I'm going to move to talking about patient engagement, but when you think about patient and family-centered care, think about a really expensive piece of paper that has a watermark in it. You cannot eliminate that watermark without destroying the paper. So patient and family-centered care is like a cultural shift in an organization that really embodies those 4 key core concepts to build a healthcare system that really is designed to work with patients and families. Next slide. So the whole terminology of patient engagement wasn't actually defined until about across the nation until 2013 when Health Affairs had an entire issue devoted to the blockbuster drug of patient engagement. What we were beginning to see in healthcare was that that some of the things that we wanted to do, reduce costs, improve quality, really could not be achieved solely by the actions of people who worked in the healthcare profession. So prior to that time, there was some consideration that patient engagement was really about compliance. Is the patient following the treatment plan that I recommended for them? And in fact, in this Health Affairs article, they really began to define it as active partnerships between the people who receive care and their families and those who deliver care. So next slide, please. There was also a study done that talked about, I'm just going to keep talking and hopefully the slides will catch up. The patient engagement was really about the actions that individuals take to obtain the greatest benefit from healthcare services available to them. So there have been a number of different kinds of definitions of patient engagement, but it's all about action and it's all about partnership to create health. Next slide. So I want to tell you a story. I want to tell you Cindy's story. Cindy was at the time a 70-year-old, she's 74 now, but she was a 70-year-old active woman who on her 70th birthday hiked to the top of this local butte to watch the sunrise. Shortly after that celebration, she got a diagnosis of macular degeneration from her eye doctor. And so she was referred to a retina specialist to follow her along. She was a person who was very physically active. She was a practicing Buddhist. She hiked and camped and did a variety of things. And this diagnosis was quite a blow to her because her mother had been diagnosed with macular degeneration, and after 10 years, her mother began to experience significant changes in her vision and eventually went blind, isolated herself, and it was a significant decline, and it was something that Cindy experienced as not a positive thing. So she was referred to somebody who had a reputation as being a very prominent specialist in this field. And what she said is that the first time she met this person, she felt like there was something between them. The individual wouldn't even shake her hand. Didn't ask a lot of questions about her background because he'd gotten some reports from the eye doctor who followed her and checked her eyes for years and years. And so she began treatment with him, and her vision began to fail, and she got shots in her eyes and those kinds of things. And after about a year of working with him, she was very concerned that her vision was deteriorating much more rapidly than her mother's. In fact, that she felt like her vision after a year and a half was as bad as her mother's deterioration when she, in the first 10 years of her diagnosis. And so she mentioned to this clinician that she wanted to explore Braille and other low vision option devices, and what might he recommend. And when she recounted this story to me, she said that his response was brusque. He told her, you don't need to do that. And basically, in her own words, shut her down with his body language and tone. She felt very disrespected and not at all a partner in her care. And when I was talking with her and asked what would she have preferred had been his response, she said, it would have been nice if he would have been curious and said, why do you think you need Braille? And then I would have been able to share my anxiety about my mom's decline and how isolated she got because she didn't have access to those resources, and how my vision was failing much faster than hers. She actually got up from the conclusion of that visit and went directly to the front desk and said, I'd like to have copies of my records. I'm going to find another provider. It was that significant that disconnect and that inability to treat her with dignity and respect and to invite her participation and collaborate with her was significant. I asked her to share what her experience was with the clinic staff was, because obviously it's a team sport. Healthcare is a team sport. And she talked about how important the technical staff had been, how encouraging they'd been, that they were consistent, even though she didn't always see the same technical staff for some of the vision tests and things that were happening over time, that they were consistent in their approach for testing. They were friendly. They asked her questions. They were interested in her as a person. And she said it brought her great comfort to know what to expect. She has since found another provider, and I asked her to talk about whether or not that partnership was going well. And she said that she felt like this individual asked her lots of questions, made her feel safe, that she could ask questions, encourage questions, would ask her, provide some options for treatment and timing, and ask her what would make more sense given her lifestyle and what was important to her. And so so she has landed with another person who has really embodied more patient and family-centered care. But I would say I also asked her what would have, what could be improved in this practice? Clearly, the new partnership with the new Retina doctor was much more collaborative in its nature. And she said one of the things that it felt like is that the eye clinic, the eye office, was very disconnected from community resources. That it would be great if there were linkages to peer support, other people who were experiencing what she was experiencing, or who could have brochures in the office about community resources. And in her particular state, there was a commission for the blind where there were lots of low vision resources for no cost. And she found those on her own, but she felt that it would have been helpful for the clinic to have provided those kinds of things. So here's somebody actively engaged in her health who, when discussing this particular situation, found that even in the best clinic, where those partnerships were there were opportunities to really think beyond the team being only those people in the four walls. I think she used the analogy of thinking of a virtual team. That the team is the technicians in the eye doctor's office, and the provider, but it also is the team of people outside of the office who help her manage and deal with her ongoing condition. Next slide, please, Tanya. So there are certainly individuals who have great technical expertise, and actually when she mentioned this situation in the context of meeting with another healthcare professional, her first experience with the retina doctor, that medical professional said, well, but this person is a real technical expert. And what I would share with you is that in order to create a truly patient and family-centered care system where we're going to engage patients meaningfully in their care, technical expertise certainly is critically important. And she wants technical expertise in the doctor that she's working with, especially around her eye. She said, eye things, it's a very vulnerable situation in her mind. But we need both. It's a both-and world. We need individuals who can create empathetic relationships and build partnership. So in terms of the continuum of patient engagement, we have engagement at the direct care level, which I just told Cindy's story, which is around direct care. But we also have the opportunity to work with patients and families and engage them in the organizational design and governance level. And I want you to realize that every organization, every clinic is on a path. They're on a continuum. It's great in direct care if we are giving patients useful and affirming information and consulting with them and then asking them questions. But where we want to go in True North really is around partnership and shared leadership, co-creating plans. And that, I think, is what Cindy was trying to do in thinking broadly about what was her plan. How was she going to create a life where her experience wasn't like her mother's, where she was very isolated when she finally lost her vision. And then as we think about improvement, and I know you have received some national awards on improvement and reduction in cost of care and things, that you're very interested in improvement. So how can you engage patients and families in assisting you in that improvement effort? And again, that's a continuum from, do we survey them to find out where are there opportunities for improvement, but can they provide input on something that we're interested in improving? I know that there have been some conversations in your organization about improving the post-surgical experience. And then how do we engage patients and families as partners to co-lead changes that we might be having? Next slide, Tanya. So those are the kinds of things that we want to be thinking about as we think about the continuum for engagement. If you want to know what the extensive evidence about PFE is, you can go out to this National Academy of Medicine report and find out more about it. Next slide. The evidence is compelling. It improves the staff experience, transitions of care, success in self-management, reduction in costs and hospitalizations. So if you want to read more about it, feel free to do that at another time. I want you to know that there's evidence out there. It's not just the flavor of the month, but that we're finding that it's really impacting care in significantly positive ways. Next slide, please. So in the TCPI program, Transforming Clinical Practice Initiative, there are some patient, person, and family engagement performance metrics that we are hoping that every clinic will adopt and will move forward and work on these really key programmatic efforts. So how do we support patient and family voices, shared decision-making, e-tool use, patient activation, health literacy, and medication management? Really quickly, I'm going to go through and kind of define what those performance metrics are and share some examples of what other organizations have done related to working on patient and family engagement in these arenas. Next slide, Tanya. But first, I want you to be sure that you understand and know, what definitions are. So support for patient and family voices is really, the intent of this metric is to really include the perspective and voice of patients and families in all aspects of operating the practice. So does the practice have policies, procedures, and actions taken to support a patient and family advisory council involving patients on practice improvement teams, on your board of representatives? There are lots of different ways that you can integrate that patient and family voice in, but the intent really is to get their perspective involved. Next slide. So what we know from leaders who have done amazing practice transformation is that there are lots of levers that you can pull to make change and make change stick and make it be positive change. But leaders in organizations that have had phenomenal results are saying that putting patients and families, inviting them into positions of real power and influence has accelerated their change. And so I'm all about inviting patients and families. I've been working in healthcare quality improvement for 25 years and inviting for that 25 years patients and families into all kinds of improvement opportunities. Next slide, please. So here are some things that you can consider. Have you considered inviting patients and families to participate on an improvement team that might be looking at improving the post-surgical experience? Have you thought about establishing, I know you have 6 clinics, umbrella patient and family advisory council that might look at and provide input on things that go across your different clinic settings. Simple things like inviting advisors to walk through the clinic and share observations of what engages them and what's not welcoming and supportive of their participation. Have you polled them about changes that you're considering so that you can hear what their issues are? And have you sought input on educational or informational materials? These are just some things that you can do to begin to think about engaging and bringing the voice of the patient and families into the setting. Next slide. I provided Dr. Allen a number of materials that we've created through the IPFCC on how to advance patient and family-centered care in primary and other ambulatory settings, and I just wanted to make you aware that it is there and you can actually download it if other people want to take a look at it. It goes into a little more detail. Next slide. I want to share some examples with you of patients and families and what they've done to work as improvement and implementation partners. So next slide. Providence Medical Group established a patient and family advisory council, and they were implementing, they have specialty practices as well, but this is an example where they implemented a patient-centered medical home, and their advisory council said, well, what does that really mean? And so they created a brochure with their patient and family advisors to kind of share this, what is a patient-centered medical home and what is the patient and family's role. Next slide. Patient portals are a great way to communicate with patients and families, and here's an example of Providence Medical Group, again, has some advisors who participated and had worked with the patient portal give feedback on the portal, and one of the things that they did is they identified that it was 5 clicks to get to their medication list, and they felt like having their accurate medication list and being able to communicate that with their clinicians was really important, and it was hard to find it. 5 clicks is too many, and so they actually, as a result of that feedback, put it on the very front-facing page when you logged into your portal. Next slide, please. Many of us are across the nation working on issues related to the opioid crisis and pain, and so they created a group to work on some materials related to pain and pain management, and so this is an example. So next slide, please. So what you see is that there are many outcomes and benefits and some specific things that advisors can do in partnership with you to improve those kinds of things. And there's lots of benefits of getting the patient and family voice involved. And I'm not going to go through this very busy slide, but one of the things that I think I've heard most from clinicians is, you know, it kind of reduces the burden when patients and families are willing to roll up their sleeves and work with us on improvement efforts, and that it's not all on us, and that they can bring fresh ideas to us that maybe we haven't thought about. Next slide, please. So I'm going to shift and talk a little bit about shared decision-making, which is a direct care strategy related to person and family engagement. So does your practice in systematic ways support shared decision-making by training and ensuring that the clinical teams really do integrate patient-identified goals and preferences? And this really is an area where what we want to do with this metric is, as organizations get more systematic about their shared decision-making, that they really are encouraging patients and families to be authentic members of the care team. Next slide, please. So here are some things that you can do as an individual when you're interacting with patients. Does the practice set the stage by understanding and documenting patient preferences in your EMR, if you have an EMR, or in your written medical record, about how they want to receive information? Some people learn best by talking or having demonstrations, and others are great with reading a lot of information. What's their preference about their loved one's involvement in care? Do we, on a regular basis, invite, you know, what are your priorities for today? What are your concerns? What matters to you about this diagnosis? Do we encourage families to be present at medical appointments? Do we offer options and treatment approaches? How do we show appreciation for their active participation as members of the care team as you are working to create decision-making opportunities for them? Next slide. So these are all things that are basic. And why do we do that? Well, one of the interesting studies, when patients achieved common ground with physicians, health status improved, emotional health improved, there were fewer referrals for diagnostic tests, and so it makes a difference. Next slide. It also, there was recently a meta-analysis and a Medicare study, comparing the experience of care for patients who were accompanied by family to those who were unaccompanied. And there were lots of really positive observations. Patients being more satisfied, the family really facilitating communication, the healthcare providers actually engaging in more sharing of biomedical information. So improved outcomes was the result. Next slide, please. So as we think about shared decision-making and as we think about involving families in effective ways, it's also important that when we are doing effective help giving, isn't just a matter of whether we meet their needs or ask what their needs are, but the manner in which their needs are being met. And so I think this is some really good literature for people that are interested on how we do our help giving in clinical environments. Next slide, please. The other thing that I think that is really interesting is that as we do shared decision making, sometimes it's useful to use decision aids, because studies show that 40 to 80% of medical information that patients get in an office visit is forgotten, and nearly half of the information is retained incorrectly. So how can we use decision aids to help improve communication and increase participation with that shared decision making? So that's an opportunity that practices often have. Next slide, please. And I want you to just be aware that there are a number of resources out there for shared decision making. Some practices choose to identify what your top 3 clinical conditions are, and then research available shared decision-making tools. There are many out on the market that are free. Mayo Clinic has created a lot. And then invite patients and families with a lived experience around those conditions to provide input about tools that you're considering. And then develop sustainable processes that outline team roles, so that it isn't necessarily the use of the shared decision-making tools that only is the burden of the clinician. It may be another member of the team. Next slide, please. I wanted to let you know that choosing wisely, and some of the handouts that you can download from the presentation are choosing wisely handouts that are that were developed and recommendations that were created by the professional society that those of you that are doctors on the call are probably members of. There are several resources with choosing wisely. It's all about creating useful conversations. Next slide. So even in choosing wisely tools that you might begin to look at for your practice, patients and families can participate and bring insights about the implementation of those tools. Next slide. So again, I'm talking about direct care things that you can do, like shared decision making. However, as you are implementing new things, you can involve the patient and family voice. It's kind of an integrated approach that I like to use. And another handout that you've got is some questions to consider when inviting patient and family feedback related to choosing wisely. Next slide. So we've got some resources for you, and what you may choose to use, what I'm trying to do is suggest some possibilities, not tell you these are the things you have to do, but inform you about what's possible, and then I'll be working with you to explore what you are most excited about and support that which makes a lot of sense for your practice. So I don't know if your practice uses an e-tool, but that is one of the PFE measures. And the intent is that we give access. It's another information sharing way, which is a tenet of patient and family centered care, access to their medical record to have direct and easy access. Next slide. Many practices find that their uptake of their patient portal is fairly low, and so sometimes there are a number of situations where you can increase your use of patient portal, and here are some examples of things that other practices have done. The other thing is that sometimes when you interview patients about the patient portal, they may share with you that there isn't a lot of functionality in there. You know, yeah, I can pay my bill, but there's not a lot of my medical information. Next slide. So I just let you know that if you do have a patient portal and you want to increase the functionality, you might consider participating in the Open Notes initiative, where you actually open the clinician's notes from the visits through the patient portal. And there are thousands of practices that are doing this, and they've done all kinds of research about how it's improved things. And that a lot of the myths about it's going to make people anxious, it's going to create too much burden on the staff or the clinicians answering questions when we just turn the notes open, are not coming, you know, those fears are not being realized, and in fact, positive things are happening. So if that's something that you might have some interest in, I've got a link to the bottom of the page. Next slide. So we're moving through the different metrics, and patient activation is a key metric. Does the practice utilize a tool to assess patient activation? Next slide. And what is important is patient activation is all about an individual's overall knowledge, skills, and competence for self-management. And what we know is when we can improve by meeting people where they're at and helping build their confidence and do goal setting in small steps and experiencing some success, studies show that we can really be predictive of the outcomes, the improved outcomes that we're going to get with certain groups. And how do we motivate people, and how do we understand how important behavior change can be in terms of managing chronic conditions and those kinds of things. And understanding a person's activation is really key to that. Next slide. one organization, Cambridge Health Alliance, decided is that they needed to think about the context from the patient perspective, and that how much time a patient spends and how it fits into their overall day for an office visit is very minuscule, and sometimes we overwhelm people by coming up with what they should do without really engaging them in what they feel motivated to do and confident to do. Next slide. And so in terms of activation, the Cambridge Health Alliance really had some particular goals as they were looking at that direct care kind of true north, which was co-developing care plans. And so they were very systematic with their teams in working from the same care plan across multiple settings, and then really trying to customize interventions based on what the strengths and challenges of the patient was, and really created a team care model so that not only the clinician but other members of the team participated in that. Next slide, please. I know that you serve a lot of patients who have diabetes and that you are interested in engaging them in ways that are useful. And I wanted you to be aware, as it relates to activation, that there are a number of patient health engagement scales and self-efficacy scales that can help you assess where your patients are at, to assist them in creating care plans and paths forward that are positive and build on their success. Next slide. Talked about how important information was so that people can take action and manage their health. And it's important that practices understand health literacy and understand how their patients are impacted. Because if we don't address health literacy issues, then we will be giving information that really kind of is missing the mark, and then we aren't going to achieve the outcomes that we really care about. If you can go to the next slide. I think that too often we assume people are literate if they have college educations, but health literacy is a little different. It's the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions and to navigate. And what's true is that practices that have addressed health literacy have made an assumption that most patients will have some difficulty comprehending health information and accessing health services. And so they implement universal precautions. They ask patients about their experience so that they can get feedback on their process. Next slide, please. And so there are a number of resources that I'll talk about in a minute, but I want you to know that there are little things that you can do that make a difference if you are aware of health literacy issues. So this is a clinic that wanted to increase their follow-up appointments to patients with diabetes whose hemoglobins were above 9, because they want to get them lower so that they don't develop some of the worst consequences of unmanaged diabetes. And they had a terrible response rate to traditional letters or to outreach through their patient portal. And so they put a small team together and they coordinated with the diabetes providers, but they also analyzed the current letter and identified gaps related to the best practice for health literacy. And they used a free place on the internet as a resource to identify what was the grade level that their letter was written at, which was way above what the recommended, next slide please, level is. And so what they did in terms of improvement is they got their letter down to the 5th to 6th grade language. They shared actual information in the letter, not just come in and get an appointment, but they were able to put the person's last hemoglobin A1C in the thing, and they used a visual so that people could see, and it would point to where they were on this scale, and a real common red, yellow, green kind of stoplight approach that people are really able to understand. So they really took a traditional letter, and as a result of it, they had a 36% increase in the number of patients that called in, scheduled their appointment, and followed through. And they did a Spanish-speaking letter and an English because they served both populations. So it was pretty cool, very small project, very targeted, but that utilized the ideas and the understanding of health literacy to improve what they were already going to improve with the patient and family approach. The other thing that they did is they interviewed the patients, because they did a small test of change. They interviewed the patients that had received the letter to get feedback on the letter and to find out what made them decide to pick up the phone and what was useful about it. So again, they integrated patient and family voices into their improvement change. Next slide, please. So this next slide we're going to go through really quick, but it just gives you, and you've got the slides so you can download them, it gives you some information about health literacy practices and things that you can do, like the Teach Fast method, that can really improve people's understanding of the information that you're sharing with them and can improve your ability to communicate in ways that are understandable. Next slide. So the next PFE metric and the last one, it has to do with medication management. Does the clinic team work with the patient or family caregiver to support medication management? And this is really all around safety. More and more we're working with patients who might have multiple chronic conditions and they're managing multiple medications. And how are they managing? What support do they need for that management? How are their families involved? That's all really important. If you can go to the next slide, Tanya. And the reason that we care about this is that the evidence shows that patients don't take their medications as prescribed 50% of the time, and over 25% of initial prescriptions are never filled. And if you go back to think about shared decision-making, if I write a prescription for somebody, and I haven't had kind of a shared decision-making conversation around this, and what their barriers are, and whether they, how likely are they to follow through on this, or how important is this to them, it may be that the fact that I haven't had those conversations in the clinic experience before I write those prescriptions may account for the 25% no-show or no-fill rate. And then what we also know is that the United States has lots of inappropriate medication use, and it increases complications and hospitalizations, and it costs us a lot of money. Next slide. And we're beginning to see that when we collaborate with individuals on medication management, we're improving outcomes. That when we actively engage patients and families, we are going to make a positive difference. So if we can go to the next slide, I want to give you just some examples of things that you can do to build partnerships for medication safety in a practice that really builds on the idea of the active partnership with patient and family engagement. So you can develop a blame-free environment and positive and trusting relationships that creates an environment that makes people more willing to ask questions or to share what they're really thinking. You can partner with patients to determine what's currently on their medication list and ask them questions about how they're managing it. You can address the burden of treatment before you add more medications to their list, because sometimes, 12 medications is too burdensome, not just for cost-wise, but just in terms of logistical, operational implementation-wise. And then try to tailor approaches to meet individual patients' needs and their situations. But the idea is really to build partnerships for patients. I happen to have had the opportunity to do a AHRQ study as a principal investigator, a very small qualitative study, interviewing people with chronic conditions between the ages of 55 and 75 on how they manage their medications, so that we could look at where might there be opportunities for error and lack of safety and things. And it was very interesting to understand from the patient's perspective where the gaps are and where the opportunities were to really build stronger partnerships with patients and families. Next slide. So we've talked about the 6 PFE metrics. We've talked about how important it is to create a culture of patient and family engagement, patient and family-centered care, the culture and the systems that support that across not just clinicians, but the whole clinical team, and how important different engagement strategies are in building those active partnerships. So we wanted to leave time, and I know there isn't a lot of time, but to begin to ask the question, what kind of direct care PFE opportunities can you imagine in your clinic setting? And think about, what are you currently working on to improve where patient and family input could be of value? Now, Tanya and Marilyn, are the lines open? Can people talk and hear each other? Because I know not everybody is in the same place physically to hear this webinar.
Yes, I just unmute everyone.
Can you hear me?
And
Hello?
people should be able to speak.
Okay. Yeah, it sounds like somebody wants to speak. Make sure your computer speakers aren't on if you're using the phone to talk. Otherwise, we'll get a terrible echo. But yeah, does somebody have a comment or identify an opportunity? Mm-hmm.
This is Deb Forty. Can you hear me?
I can, Deb. Hi.
Hi, how are you? Thank you so much for putting the seminar on. You know, there's so many aspects of this where we've started to implement just little parts.
Mm-hmm.
Our surgical coordinators, we make sure we have our disclosures signed because so many of our patients, as you mentioned, don't necessarily have blood relatives, but have others that are helping to do their caregiving. So there are little bits and pieces that we are working on currently that I can see where it will benefit us to, expand our outreach a little bit more. But
Great. So that's a real tangible thing that you can kind of systematize across all your clinic settings. That's where policies and procedures across a large organization like you have can be really important, because sometimes you try things in one area and it's really wonderful, but how do you take it from the really small micro clinic level to a common experience for all patients and families? And that was one of the things that was a big aha to me when I was interviewing this individual, Cindy, about how much comfort and confidence the fact that the organization had in terms of being very standardized in the way that they did procedures, so that she didn't see this wide variation in what she was going to experience from the technicians and the nurses in that clinic setting can make a big difference. Are there other opportunities that people can imagine?
Hi, this is Kristen. I work in the uveitis clinic at Colorado Retina.
Uh-huh.
And we actually only have one FDA-approved drug for our patients. Everything else we use is off-label, as we are an orphan disease. And so we're considered one of the specialty clinics. We are actually meeting with the makers of that drug, AbbVie Pharmaceuticals, and they have a huge program within AbbVie that they completely fund and sponsor, and it is a nurse ambassador available 24/7 to patients. So beyond just the resources in our office, there is a trained RN available at all times to patients with questions about their medication. And they do everything from injection training to reminders for injections, follow-up. You know, it's open enrollment. How do I know what plan to choose that covers my medications? So we really try and advocate with our patients, but we encourage them and follow up with them to make sure that they've enrolled with a ambassador to help follow those things, to really make sure that they're compliant with their treatments. And I think getting them connected with resources like that really have improved our compliance in terms of just staying on the medication in general, but also when they have questions, who to go to.
Yeah, and that's a great example of a virtual team that you've created. And so what I think is really great from these comments that you guys have made is that you already have got some good things in place, and you want to build on what you already have in place that's good and see how you can expand it, can evaluate and assess other opportunities. We obviously, because we have to be done in 5 minutes, aren't going to cover all the opportunities that there are. What I would ask those of you that are on the call to do is to maybe jot down and think about these 2 questions, and then begin to have a conversation and share that, so that what the organization can do is gather some suggestions and recommendations and best thinking of the staff and the clinicians about where might we start. Tanya, can you go to the next slide? For instance, when I talked with Alan the first time, he brainstormed a couple things, working with the inherited retinal disease clinic team on a specific project, or improving the subspecialty care team care coordination, or improve the post-surgical experience, or work with the lean consultant on integrating patient and family voices. There's lots that you can do. I think what we wanted to do in this webinar, and I know some of your colleagues who aren't joining you today will be able to hear the information and get kind of the foundation down, common foundation, is to begin the conversation and then create, next steps. And we're not going to do that in this webinar, but I'll be following up and we'll be setting up some calls with key people to think about next steps and have a path forward. So next slide, Tanya. So those were some ideas that just came up with just a little bit of brainstorming. I'm sorry, I have another commitment with about 50 people in 3 minutes, so I can't really run over because I'm hosting that commitment. But there may be some questions that I haven't had a chance to answer, but you're gonna, through PCPCC SAN, I'm gonna work with you over time on this, so we don't have to, boil the ocean in one day. And so just as you're gonna write down some ideas about opportunities, or start with writing down what you're already doing that you think addresses some of these engagement strategies and ideas and things, and then think about what the opportunities are. Also, just gather some questions. And Debbie, would you be the person that, as people are writing ideas down and stuff, that they could send it to you at a central place where it can kind of be collated?
Yeah, if they want to just email it to me, that's fine.
Great, great. So questions can be emailed to Debbie, and ideas, and even strengths. Let's start with a celebration of the strengths of all the great stuff that you guys are doing. Next slide, Tanya. There are in these slide decks some information about resources that Marilyn talked about, and the next slide is about PFCC Connect and how you can sign up for it if you are interested. It really is an online learning community, not just for patient partners, but for those people who are really interested in truly implementing patient and family-centered care principles. And then the last slide really is, I want to thank you so much for the opportunity to work with you. And my contact information is there, and I'll work with Debbie and Alan to begin to think about next steps together. And after everybody's had a chance in the entire organization of getting some ideas to Debbie, and so we'll be in contact. We'll be building a relationship together. I'll be learning from you, and I'll be able to share with you some of the great things that other people across North America have done in partnership with patients and families as food for thought for your organization to move it forward.
And this is Marilyn, I just wanted to thank you for reaching out to us, and we really look forward to working with you. And the contact information for Tanya and me is on the, I think they're also on the slide, but I think Dr. Kamira also has our contact information as well. Okay.
We appreciate it. Thank you very much.
Okay. Enjoy the rest of your day.
Thank you. You too. Bye-bye.